Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and we're back in the Sunflower House for this newest episode of our Speaking of Women's Health podcast. And this one's interactive, and I'm so happy to have a guest. Her name is Teresa Ryan. She has her MS and her registered nursing degree, and May is Nursing Month. And she's also an access and reimbursement specialist. And she's had 35 plus years working in a variety of healthcare settings. Her previous experience includes working in an acute care hospital setting in critical care and women's health, cancer care, and case management. She's also worked in physicians' offices and worked with infusion centers, and certainly in our Center of Specialized Women's Health, we do a lot of osteoporosis work and also do infusions. Right now, Teresa Ryan is currently working with specialty medications to assist clinicians in navigating Medicare and health insurance payers, which is very complex, I must say, to obtain access and reimbursement for prescribed specialty medicines. And this includes prior authorizations. And in the future, I'm going to have our nurse, Alexandria De Los Santos, who's our lead nurse in our Center for Specialized Women's Health, come on and talk about prior auths and how to get medications for lower cost. So her areas of expertise include payer medical policies, medical necessity, coverage, reimbursement challenges. And she's got particular expertise in how Medicare and health insurance provides coverage and reimbursement for both medical and pharmacy services. And when I was talking with her last month, I thought, oh my goodness, I've been in healthcare as a physician myself for over 30 years, and I never even thought to think about some of these issues. So I thought our lovely audience in Speaking of Women's Health really wants to know about this. Now, in terms of her education, she has a BSN from Mount St. Joseph University and an MS in Health Administration from Central Michigan University. And she loves her entire varied nursing career, and she really likes making differences in the life of both the patient, the clinician, and the office staff and her colleagues. And she likes problem solving and teaching. And she wants to make sure that her patients get the right therapy and care that they need. On a personal note, she's been married for over 40 years, so she slightly beats me. She has 3 daughters. I have 3 sons. And she really beats me. She's got 6 grandchildren, and I'm expecting my 3rd. She likes to travel and spend time with family and friends, and she's traveled all around the United States and other countries. And she thinks that travel gives a really great, deep appreciation of the world, as well as a deep appreciation for home and family. So welcome into the Sunflower House, Teresa.
Well, thank you, Dr. Thacker. Thank you for inviting me. I haven't heard my introduction quite that. You write those things down, but it's so nice to hear those and reflect on all the different nursing and family experiences that I've had. And thank you for inviting me. I really am excited to talk about insurance and coverage and how that impacts patients' decision-making when they need to ensure that they are using those insurance plans to help cover the services their prescriber is ordering for them.
Yes, I think that is so important. And I know as a physician prescribing, May is Osteoporosis Awareness Month, and I've been in the field of osteoporosis for over 30 years, and it's been exciting to see the expansion of treatment options. And for women with severe osteoporosis and very low bone densities who are at very high risk for fracture, serious bone breakage that can really affect their independence, mobility, and their lifespan, we do give infusions and injections. And I've been dismayed that when we get the coverage and they start on therapy and then the new year comes and it's either not covered or it is covered with a super duper high cost. So it's covered, but they're going to pay, hundreds, if not thousands of dollars that they can't afford. And until I met you, I didn't even understand why that was happening. So it's going to be so good to get into this. And even if our listeners, you're healthy, you don't have any problems, you're not expecting biologic therapies for rheumatic diseases, which disproportionately affect women, I think this is such important information to have, because maybe a family member or a friend or down the road you may have these issues. So first, Teresa, tell us, what does an access and reimbursement specialist do?
Our role is to, once the prescriber has made a decision about what therapy they want their patient to receive, then the next step for certain types of imaging studies, medications, they do require oftentimes approval. So does that patient's plan that they have, does it cover that procedure or that medication? And if it covers it, what is the patient's out-of-pocket impact going to be? And is a prior authorization going to be required? So access specialists on that side, we help to navigate through that patient's health plan, verify coverage, we verify a prior authorization or predetermination status, and then we look at what's going to be that patient's out-of-pocket impact, and are there financial assistance options available to help that patient based on what that out-of-pocket impact might be. And then on the reimbursement side, we work with providers, hospitals, clinics to ensure that they bill the various payers correctly. Mm-hmm. And billing has its own set of complexity related to codes and settings and all of those various requirements. So we want to make sure that we submit that. We call it a clean claim, that all the payers' requirements are submitted correctly on that claim. So that claim is then adjudicated timely, and we're leveraging all of the benefit that that patient's insurance plan has related to what gets paid. And the other aspect on the reimbursement side is, did our provider receive what they were expecting for reimbursement? Did the patient's responsibility, was that clearly identified? And does the patient understand what out-of-pocket they might owe and how that needs to get successfully paid? So we're looking at that whole process from the time the provider orders and prescribes that treatment, medication, or therapy, all the way to, did all the correct reimbursements happen? If there's any denials along that pathway, did the prior authorization not get approved? We're able to help with those appeals to make sure we're articulating clearly how that patient meets medical necessity for what's been prescribed. Or if there's a denial on the reimbursement side, well, let's find out, why did this get denied? How can we help appeal that to get that denial overturned so people receive the correct payment?
Well, you're sure an expert in insurance, and that's one of my little pet peeves. The term provider is kind of an insurance term. Like, I prefer physician, clinician, nurse practitioner, because they're really truly making the best assessment that they can for patients. And I've often wondered if sometimes, especially people that practice with patients primarily over age 65, where it's Medicare and they know what Medicare covers or not. Like, for instance, for cataracts, I think it has to be a +4. I'm not an ophthalmologist. This is not medical advice. Again, talk to your own physician in terms of podcasts. But I know personally, I would probably want, if I had cataracts, them fixed sooner rather than waiting until I'm practically blind. And I had a friend who had Dupuytren's contracture of her hand, and, she was poking herself in her eyes, washing her face, but the hand surgeon kept saying, oh, it's not ripe yet, it's not ready. But what if she just wanted it done sooner? She probably could have had it done, but then Medicare wouldn't have covered it. And I think sometimes maybe physicians and surgeons just know that the patient can't pay that out of pocket or doesn't want to, or is going to hound their office for coverage for medical necessity when they already know it's going to be denied. So I mean, I just think that's a tip that people should plan ahead, try to have money off to the side, and understand when they say it's not ready to have this procedure done because you're not bad enough according to their guidelines, which aren't going to budge, but you still, as a patient, may want to choose to have intervention done sooner, but you're going to have out-of-pocket cost. So let's dive into some of the insurance details. And can you tell us what is different between Part A Medicare and Part B, and what do these parts cover, and how do they impact patient cost? And when should people start thinking about this? I presume before age 65.
We'll be back after a quick break.
Hey, quick question for you. Are you someone who wants to be fit, healthy, and happy? And what if I told you you could get your dream body by simply just listening to a podcast? I'm Josh.
And I'm KG, and we're the hosts of the Fit, Healthy, and Happy podcast.
Listen, we get it. Fitness isn't easy. Carbs, no carbs.
Just stop, okay? It doesn't have to be that complicated. And that's why we made this podcast. We get straight to the facts so you can become your best you.
So the way to check us out is click the link in the show notes or search Fit, Healthy, and Happy podcast on any of the major podcast platforms. We'll see you soon.
Correct. Well, everything that you were just saying has a lot of things we can talk about. So before we dive into the parts of Medicare, I want to talk about a couple things that you identified when you were sharing some of the challenges that you and your patients experience just in trying to get, when are they ripe, so to speak. I love that term for that insurance plan covering whatever their healthcare need might be. So I appreciate provider is definitely an insurance word. When you're on the clinical side, we don't call ourselves providers, right? We are nurses, we're physicians, we're nurse practitioners. We're there assessing and diagnosing patients and helping to identify what's the best treatment, medication, based on your experience and your expertise for that patient. So there's that aspect of healthcare that oftentimes feels like it's in conflict with what the insurance company, whether it's Medicare, a Medicare Advantage plan, or a commercial plan, has decided they will cover. So all of those various insurance providers have what they call medical necessity criteria. Many of those medical necessity things are based on whatever the FDA has said the prescribing information or the reasons to do those procedures or tests. But they oftentimes will include some step therapy requirements in there. So for example, with a cataract, they're going to treat that medically until it gets to a certain level that they've decided, then that allows for approved surgical intervention. Same like with total joint surgery. Patients have to do other medical care and therapies and all those things before they will approve, this patient is bad enough or ripe enough to now require a surgical intervention. And it's the same with medications. Many of them will select a less expensive cost or a generic option before they will, and the patient has to fail or have a contraindication for that drug before they'll approve, a more complex specialty medication that costs more money, etc. So that is often the conflict that we all experience every day. What your physician, your nurse practitioner wants to prescribe based on their knowledge and expertise, not always in alignment with what the insurance company has said, well, this is what the medical necessity requirements are in order for us to cover that prescribed treatment or therapy. So that's very frustrating. It gets everybody, it takes like a lot of administrative time because you have to know what that information is. You have to complete forms and documents, etc. So that is definitely a pinch point of pain for many of us in healthcare and is in a conflict with each other.
So tell us about what Part A and Part B in Medicare is.
So patients who are 65 or older are eligible for Medicare. We want to make sure they sign up timely because there's penalties if you don't. Medicare Part A covers hospitalizations, home care, hospice care, so that acute side of skilled nursing care, that's what Part A is covering. Part B, as in boy, covers all of your outpatient services. So it covers physician office visits, outpatient lab work, specialty drugs that are administered by healthcare providers, certain imaging and outpatient infusions, etc. All of that goes through your Part B, as in boy, plan.
Does
Now,
everyone have to sign up at age 65 if they're a United States citizen?
Yes, so if you don't, you'll have a penalty. So yes, and you can do it 3 months before you're 65, when you turn 65, and 3 months after. So there's like a 7-month window in there for patients to sign up for Medicare when they're in that window of turning 65. Now, if you are still working, which many people are at 65, they're healthy, they're working, they enjoy it, and they're paying a premium for their commercial insurance coverage. A lot of times our 65 and older patients will just have Part A. They will delay signing up for Part B because they're going to use their commercial plan that they're already paying for through their employer to cover those outpatient services, and that's allowed. But then once that patient wants to sign up for Part B, then they want to do that within the correct time frame of when they no longer are working and they start taking Social Security, then they have to sign up for Part B at that time. If they don't, then you jeopardize a couple things. You have a penalty that you didn't, and it will be more expensive if you want to sign up for a supplemental plan at that time.
Is there a Part C or a Part D?
There is. So Part A is that acute care hospital coverage. Part B, as in boy, is all of your outpatient care. Part C is called your Medicare Advantage plans. They fall under that Part C. And then Part D, as in dog, is for your prescription plan. And then there's another option in there that is called a Medicare supplemental plan. And the supplemental plan is what patients would sign up for when they sign up for their Medicare Part B. They would that's their time to decide, do I want to purchase a supplemental plan or do I want to purchase a Medicare Advantage plan? So that's when patients have to make that decision. So Medicare Part B, as in boy, covers 80% of your outpatient care. So you pay an annual deductible of $226 for this year. And anytime you have outpatient services, you go to your physician's office, your specialist, you have lab, x-rays, other outpatient procedures, you always have a 20% copay for each of those services with Medicare Part B.
So then a person gets to pick this is it October? Is that when the enrollment time is that they can switch their supplemental insurance?
So Medicare re-enrollment is every fall. As you said, they start getting noticed in October. I think it opens like the beginning of November. So if you want to make a change in your current enrollment, that's the time that you can do that. So if you have a Medicare A and B and you've purchased a Medicare supplemental plan, then in the fall you would re-enroll in that supplemental plan to make sure you know what your new premium might be and any coverage changes. The supplemental plan is going to cover that 20% that your Medicare Part B doesn't cover.
But does it
typically.
vary? It seems like some of the plans are capitated, because when I try to prescribe certain medicines, it automatically does all these stop gaps in the electronic record and is pushing me to the generic or the cheaper drug, which a lot of times is fine, and I would already do automatically anyway when giving the patient choices. But sometimes that's not the case, and that's not the appropriate therapy, especially I think in the osteoporosis and rheumatologic spheres. I'm sure, it might be the same in cardiology and, other fields as well, pulmonary, GI, etc.
So yes, all of those payers have what I was referring to as medical necessity requirements. So you have to meet whatever that insurance plan's medical necessity requirements are for your prescribed treatment, therapy, etc. So we were talking about osteoporosis. So Medicare covers a DEXA scan every 2 years to evaluate that patient's bone density. So if you do it less than every 2 years, you're not going to have the same coverage, and you could even have denial in that coverage. So unless there is a medical reason to do it more frequently, that would have to be documented and approved.
So excuse me, are you saying that you can get penalized if you don't do it every 2 years if the person has osteoporosis, or only if you do it more? If you do it more frequently.
Well, yeah, you're not going to get penalized. But you would want to, monitor your patient. If you do it less than every 2 years, if you would order it, it could be not paid
Sure.
Unless there was a medical indication of why you're doing it,
right,
less than what the medical necessity criteria outlines.
Because sometimes, and I explain that to patients, it's a whole 7 years for the entire skeleton to turn over. So doing it in another year doesn't tell you anything. You have to wait at least 2 years, unless someone's on steroids or transplant or really unusual situations. However, I found sometimes I don't like to always do the bone density within 2 years if I know the person's getting a really good therapy, like say, an injectable denosumab Prolia, because I know my nurse is giving it to them. I know what the research shows, because sometimes if the bone density improves too much, which we're always happy to see stabilization, and then if things are improved, we're even happier. But then I've seen them denied. So I don't know if they're denied because now their levels are better, or if they're denied because they switched plans and the plan just doesn't have as good a coverage. So how are patients supposed to figure this out?
So it's not going to be denied if the patient is improving, because osteoporosis in your example is just like hypertension. It's a chronic illness. And so you're prescribing medication to treat that chronic illness. And as long as that patient is taking that prescribed treatment, then that chronic illness may be controlled or managed.
Yeah, I definitely had the experience where the person had osteoporosis and they improved to osteopenia, and the insurance company said their T-score is just too good, they don't qualify anymore. So that's why sometimes I extend the monitoring. And there are times people improve and we don't have to use as intensive therapies because we've corrected underlying problems. But in a lot of women that are older and postmenopausal, you can't change the age and you can't change the fact they're postmenopausal.
We'll be back after a quick break.
Have you ever experienced fitness failure? You set a goal to exercise, you're all excited, and then you're not. Hi, I'm Dave. I host the daily 10-minute podcast, Walking is Fitness. Instead of an exercise goal, I talk about making a fitness promise. And every day you keep that promise, you add another link to a growing fitness chain. This is a podcast of action. You'll create a fitness habit, which eventually becomes fitness momentum, and then on to all kinds of good stuff. Check it out. Walking is Fitness, and let's take a daily 10-minute walk together.
I think if you get a denial on a patient, that's when you call your access and reimbursement
Okay,
specialist.
I've got your number.
We're going to come in there and help with that because the patient always has osteoporosis, and we have insurance plans that will ask for what was the baseline, the original DEXA scan in this example, or the original study you did of the patient's hypertension, et cetera, where you identified the diagnosis. And then if you're doing follow-up blood pressure monitoring, for example, you're showing that the medication that patient's on is effective. So the patient has good efficacy with your treatment plan. You're going to continue to, monitor that patient's treatment. With osteoporosis, if they're whatever medication you prescribe for them, Prolia or whatever, if that's showing to be effective, sometimes they'll ask for the original, and then they want to show that you're having a good efficacy. So then you do a follow-up one that shows that patient's bone density has improved. If it would get denied because now they're saying, oh, well, they're no longer osteoporotic, definitely contact an access and reimbursement specialist, because we are very skilled at writing that appeal letter that says, no, we're not going to interrupt this patient's therapy. That's being very effective. And
But sometimes,
so they shouldn't be doing
but sometimes
that.
what happens is they'll go ahead and say, okay, we approve it, but now the patient has to pay a lot more money. So what are some tips that you have for people that do have a higher burden of disease that they may, I presume, need to pay higher premiums for better coverage, but in the long run that will save them money because they won't have as much out-of-pocket cost?
Yeah, that is I love that question. And the reason is patients sometimes are looking at, well, how much is my premium for either my supplemental plan or my Medicare Advantage plan? And they're making choices of what plan they're going to purchase based on that premium amount without a full look at, well, what's that deductible going to be? Is there a copay with this plan that I'm purchasing? What is that copay amount? Does this plan that I'm purchasing have an out-of-pocket maximum requirement? So sometimes patients don't look at the full picture of what am I paying for my premium and balancing that with, well, what's my deductible and out-of-pocket impact? And if I'm pretty healthy and I don't go to the doctor very often, I don't have a lot of medications or specialists that I see, well, then purchasing that Medicare Advantage plan with a lower premium might be the perfect financial decision for me. But if I'm a patient who has a lot of healthcare needs, I see a lot of different physicians throughout the year, specialists. I have ongoing lab studies, imaging studies. I take specialty drugs to treat different problems that I have so they're controlled. Well, then my out-of-pocket is going to be much higher because I'm having to meet that deductible. I'm having to pay a copay every time. So maybe purchasing a little more expensive coverage on the premium side is a better financial picture for me. And so in order for a patient's not going to necessarily understand that. So we have something, they're called it's SHIP, state health insurance providers or program people. They do a lot of free counseling. So they will sit down with a patient. They'll have them bring in, what are their healthcare needs and associated cost impact. What plan is going to be the best for them related to how much they're paying for the premium each month versus what they may be paying out of pocket for healthcare services that they need.
Who funds those people that are providing this free service?
It's funded by both federal and state funds. There's no cost for a patient. So you would just go online and you would you can type in, for CMS has lots of government options available to help people, and you would type in Ohio insurance Let me look
You
it
know
up
what?
again. I want to make
What
sure
we'll do is we'll put a little link and a little
yes,
story with these highlights and these website links. So our wonderful executive producer, Lee Kleckar, she'll do that so that anyone listening to this podcast can go on speakingofwomenshealth.com
perfect.
and we'll have all these links and tips for you. And we're in the Sunflower House. We're talking with Teresa Ryan, who is a expert in access and reimbursement. So I've seen advertisements on television in the past where like a local pharmacy chain said, well, you come in and talk to the pharmacist and we'll give you a free consultation based on your current list of medicines. And I know as a menopause and hormone expert, I have patients and I do anticipatory guidance. I'm like, okay, you're doing really well in this hormone program. And certainly after age 65, sometimes we do lower the dose. Sometimes we go to transdermal to reduce stroke risk. But I tell them, you've been fine, and this is treating so many different medical issues, and you want to continue on it even though you're over 65. But in my clinical experience, most all the Medicare secondary insurance doesn't cover hormones. They list it as high risk based on old criteria that we have tried to many times advocate to the federal government that if you're on hormones and you're just continuing them, it's not high risk based on old Beers criteria. But Medicare will ding doctors. They'll give them less money for the office visit if they have more than 7% of their women patients over 65 on hormones. And I think this is ageist and sexist. And I let patients know this is the facts. And a lot of my patients have to actually buy their medicines for cash or go online. And in future podcasts with other nurses, we're going to go into detail on that. So please tune into that and read our column on how to save money on medicines on Speaking of Women's Health. But there's occasionally some secondary insurances that surprisingly will, I'll be shocked because, you know, out of 100 patients, most of them don't have coverage, and then I'll see one that does. So is that a legitimate service to talk to a pharmacist and they can run and say if you're on these medicines? So people should talk to their pharmacist too.
Yeah, pharmacists are great advocates and good resources. They're able to really understand what that patient cost is based on the health plans they have. The State Health Insurance Assistance Program is a good resource. They will help you look at the various plans and what your healthcare needs are to help you with that. That's that SHIP resource. If you're a low income Medicare patient, they're called LIS, low income subsidies are available for our Medicare patients who can't even afford the Medicare Part B premium. If they qualify as a low income Medicare person, then they can oftentimes get those things for free. So there's a ton of resources. So I love your idea to put those links out there. It's hard to listen to this information because it is complicated. I don't know why they want to make it so complicated, but you know, we're here to answer those questions and help those patients navigate what's the best choice for them. So those resources are out there.
It really does take a lot of work. You know, my husband, who's not medical, people would know that I, you know, work at a large hospital, and they would call him like, well, how do I do this? How do I do that? And I can't get an appointment, or they'd have all their complaints to him. And he's like, well, they're just, you know, you just have to be, you know, with it enough to figure it out. And it's not like just rolling into, you know, your favorite fast food restaurant and ordering whatever, you know, quick meal that you're used to getting right away. It really does take some time and planning and resources and checking with people and really planning for it. And we have women plan for pregnancies. We have women plan for perimenopause and menopause. And so I do think planning for both retirement, planning for Medicare, and how you're going to fund all of this, and just, you know, planning other things financially, and, you know, other aspects of life is a very important thing to do.
Well, I did want to say something about I love your comment about the planning part. Is in my own experience with family members, they think once they sign up for Medicare that they don't have any more, that they don't have to pay anything for
Yeah,
health
not
care,
so.
that everything is correct. So, you know, Medicare Part B, you do have to pay a monthly premium for that. That right now it's $164.94 a month. It can go higher than that based on what your income is. When you sign up, they'll let you know what that premium is. It's not free. And so you still have to pay a premium. And if you don't purchase a supplemental plan, you have to pay 20% for all of your outpatient services. If you purchase a Medicare Advantage plan, some of those plans are great. They have great coverage, but you may have a deductible. You're going to have a copay. You won't, and people don't expect that. They're like, wait a minute, but I have a Medicare Advantage plan. Doesn't it pay for everything? No, it doesn't. So I think you're exactly right. People need to use those resources. As you sit down with your financial planner for retirement planning, you should sit down with that health insurance assistance person, which doesn't cost you any money. You don't have to pay any money to them. They will help you do planning then. What's the best health insurance coverage for you, to support your Medicare that you are now eligible for. You can find those people like I said, there's no cost. You can find them at senior citizen centers. A lot of hospitals through their business office have people who volunteer. A good friend of mine, that's what she is. She does that. It's called OSHIP. So we have to say that always carefully. She does counseling, and she loves that. She meets with her senior citizen patients to help them make good choices based on what they can afford for both the premium side and what they can afford when they have to have healthcare services.
And one question that comes up, because a lot of people who might be used to commercial insurance through their employers, that some things are covered only for wellness, whereas sometimes it's only covered for actual treatment. We physicians and nurse practitioners and physician assistants, we just have to document what we do and code for what's done, and then it gets subsequently billed, and you can't get involved obviously in insurance fraud. There are some things that are truly preventive, there are some things that are truly diagnostic and therapeutic, and then sometimes people need both types of services at the same visit, or maybe billed for two visits in one potentially. And so there's a lot of confusion on, I think, both sides with commercial insurance and Medicare. And I know just from being a women's health physician that Medicare will cover a women's preventive annual exam every 2 years, like for breast and pelvic exams, which for most women, if they're not having active problems, that is acceptable. It might be different for younger women who need yearly exams and more frequent PAPs when they're younger, but medically, I do think that's appropriate. But I know that patients get hit with a form at the front desk that they have to sign that they're going to be financially responsible if they want an annual preventive visit that's not covered. And conversely, if they see their primary care doctor for that annual, then sometimes that's not covered from the gynecologic standpoint. So I know some women, based on their insurance, they rather go to their women's health person for their annual exam. And I'm going to have our nurse practitioner, Dana Leslie, on, who does a lot of those great exams for our patients, on a future podcast. So do you have comments on what people need to know about Medicare and other insurance plans in terms of wellness and prevention?
I think that's a common complaint, that sometimes wellness and baseline screenings aren't covered. I do think that has improved over the last few years, where they're including coverage for wellness care. I know I had to have my vitamin D level checked just because of my age and that I work more indoors. And my physician, she does a lot of women's health. She said, just so you know, insurance probably won't cover a baseline vitamin D level. Although I know you're at high risk for low vitamin D based on your history and your age. Once we diagnose you as low vitamin D and we're doing subsequent testing, well, then it's a covered procedure. So I had to make the decision, well, I'm just going to pay for that out of pocket, because I want to make sure I'm not low vitamin D, because low vitamin D affects so many aspects of your health, right?
Yeah, our second podcast was on vitamin D, so please, people, go back and listen to that. It is so critical.
It is, and I as a nurse, I'm aware of that, and not surprising, my vitamin D level came back suboptimal, and so I had to start taking an additional supplemental vitamin D. So, but since then, I spoke with our benefits people, and I'm like, why would you not cover this? I mean, it's not terribly expensive, but it has a significant impact. So talking to, advocating with those various benefit people to look at coverage, working with your medical associations who then communicate with those insurance payer reps, more and more wellness things hopefully will be covered, because you want to try and prevent disease states that are way more expensive to manage and treat. So, and they're associated with way more morbidity risk and even mortality in some cases. So I think it's better than it used to be, but it is still not where it should be. We're not very good at doing good wellness management and helping our insurance plans cover that.
Well, we certainly have a lot of proactive information on our website about being strong, being healthy, and being in charge. And a lot of health prevention and promotion has to do with lifestyle and diet and exercise and good sleep. All of that stuff we have on our website, and just kind of staying armed and up to date with the latest information. So as we wrap up, Teresa, do you have some thoughts on future trends that kind of impact Medicare and just health insurance coverage in general?
Now, that's a great question. I think the most important thing is to know what it is you're paying for. So to do that homework ahead of time, to understand what am I paying each month for my premium, and what am I out of pocket impact going to be for any services that are prescribed for me. So that's the first thing. I do think as far as going forward, the government has done a better job of changing some of the coverage for Part D, as in dog, which is the prescription coverage. It used to be if patients had a lower threshold, that once they met that threshold, they would have to pay a lot more out of pocket for their medications.
Is that the donut hole?
And the donut hole. And that number has been, and it was super complicated to try and explain like a donut hole and what that means to a patient, or even to what our physicians, was ridiculously complicated. So there was a lot of advocacy to change that, and that has changed. They've raised the limit. It's less complicated in the calculation of what that patient's cost impact will be. And those pharmacists out there are great resources to have a good understanding of that. So that's a positive change that has happened out there. This year, Medicare lowered the premium for Part B and lowered the premium for what the deductible is. So that was a good thing. They've allocated more resources into helping those low-income Medicare patients qualify and be able to get access to better coverage when they can't afford those premiums. So those are some very positive things.
Well, nothing's for free. So when one thing goes up, there's someone's got to pay the piper at some point. So I think having everybody involved in understanding what costs are and doing their part to not waste resources and be proactive, I think certainly will help all of us. One trend I wanted to ask you about, and I'm kind of sad to say that my graduating senior fellow, who's written a lot of great things on speaking of women's health and done lay events, Dr. Alexa Fiffick, who I'll have on an upcoming podcast, I offered her to join our staff, and she's going out into the brave world of cash pay, direct primary care, concierge care, which I think is a big trend. And I guess they just recommend that people only keep catastrophic insurance for like hospitalizations or surgeries.
Right.
But instead of paying all this insurance premiums and getting extra billing because so many people don't pay for care, so then the hospital systems or organizations that provide the care have to charge the other people with insurance more, and it's just very complicated. And even though there's transparency laws to let you know how much you're going to pay, it's still, to me, very confusing as someone who's been in this field. So I wondered if you had anything to say about that trend.
Yeah, that's a great trend that's out there. I actually work with those offices, and mostly they tend to be in urban environments. But that's right. There's a couple different models. There's a model where a patient pays a monthly premium to that physician organization. And in return for that, they're getting their care, they're getting access to their providers, and they're only keeping that catastrophic issue, like Part A, which covers hospitalizations, emergency care, that kind of insurance. And they don't purchase the other insurance. They pay this premium. It's kind of like a membership fee into that healthcare provider organization. And then so that's at one end of that. Then there's on another end where they don't pay anything up front, but as they receive services, they pay that through cash or credit card, whatever that organization has decided that's going to cost. So that is very much out there. I have a good friend of ours who has prostate cancer, and the clinic that he's going to is one of those clinics. This physician and surgeon has his own surgery center. He negotiates what the price is going to be with his patients that come to him. He doesn't take any Medicare assignment. He doesn't take any insurance. He doesn't have any of that overhead. He negotiates directly with the patients of what they're going to pay. So that is definitely out there. And patients who have good understanding of that and maybe have a little more financial security, they're able to do that. Not all patients can adapt to that because they don't have the money to do that, or they don't necessarily have the understanding of how that would work. So, but it definitely is a trend that's out there. I see it more and more, particularly in urban areas.
And then those groups of physicians sometimes actually are able to purchase medications directly themselves and then dispense them to the patient. I imagine that must change based on state law because physicians aren't pharmacists. But I know that there's such a jack up in cost of medicines through the pharmacy benefit managers. And also with lab testing and x-ray, like a lot of people want to go to other freestanding labs or x-rays or CAT scans, and they pay cash or they get it much cheaper because it's not otherwise in some big bundled service.
Right. So that's true. And there are different rules in different states about that. And I think because it is a newer trend, I imagine some of those laws are going to evolve over time. So it'll be an interesting push and pull between the government and non-government entities, working to decide how those things are going to work. Physicians can't dispense medications, correct, but they can purchase them from pharmacies and then inject them in their offices and then collect that money from the patient. So there are states that allow that. That's not a problem. So it'll be interesting to see how that evolves and changes. There's a lot of competing interests out there that are going to influence that.
On our recent osteoporosis CME podcast that were for physicians and nurses, but a lot of our general audience likes to listen to, one of my graduates, who's an expert in osteoporosis, Dr. Christy Tuff-DeSapri, is in Illinois, and she has opened up a cash pay concierge practice where she doesn't accept insurance, but because she's an osteoporosis doctor and based on Illinois law, apparently she can't bill the patients for, these osteoporosis infusion drugs. The osteoporosis Medicare part of her practice is going to have all that billing and coding. But it's very complex, and I can see why a lot of physicians and surgeons just say we're not doing this, we're going straight cash pay. And for some patients it's actually more affordable, and that's
Yes.
definitely a practice option, but it just does make for the complexity. So we'll have to have you back on a future podcast. Thank
I'd love to.
you so much, and thanks to all of our listeners for joining us in the Sunflower House. You've been listening to your host, Dr. Holly Thacker, the Executive Director of Speaking of Women's Health, and our wonderful guest, Teresa Ryan. Please be sure to subscribe to our podcast wherever you subscribe to podcasts, and give us a 5-star rating. That helps us move up in the ratings, and we'll look forward to joining you back in the future in the Sunflower House.